So as you know, by watching the agenda move forward, this is the last session. And as you've heard throughout the conference, the theme was evidence to action. And this session is about action. So we wanted to have a chance to have a good discussion about actions and how we move forward and how we precipitate some positive actions. We've got a great panel here. The way we'd like to do this, we'll have a few minutes for clarifying questions after each of the talks, but want to allow sufficient time at the end so we can have a broad discussion, not only so you can probe the presenters, but a chance to hear from all of you about what you think needs to happen next.
So the next speaker is Adwoa from WHO to speak on issues related to revised global typhoid vaccination policies and strategies. She is the focal person for typhoid vaccination and vaccine introduction in endemic countries. Adwoa.
Thank you, Narendra. First of all, I apologize that my voice is going to be raspy, and I might have to take breaks now and then to take a sip of water. But those of you who've been sitting at the back of the room have seen the staff here plying me with copious amounts of dawa, which I'm told is the local word for medicine, but it was essentially ginger, lemon, and honey. So I thank you all, Christine and Juliet and the team, for making it possible for me to give my talk. Thanks to Denise and the Sabin team for inviting me to come and share the WHO perspectives here. And what I'm going to attempt to do is to actually show that much of what, indeed, all of what we've heard about these last 3 days are going to feed into the policy decision-making process for vaccine introduction. And I think that's heartwarming for you to see how your work contributes to that. So let me start, first of all, by giving you a little bit of a direction for those who are not familiar with this. Just come on this walk with me as I take you on the pathway to policy development at WHO. On this slide, you see on the left, in the blue box, the representation of the WHO guidelines for manufacturing, licensing, and regulation. It's sometimes called Guidelines for Quality, Safety, and Effectiveness of Vaccines. And in this meeting yesterday, or the first day, some people refer to it as the Technical Report Series, or TRS. That's the process providing guidance and standards, norms and standards for vaccine manufacturers for ensuring high-quality vaccine production. So that's one thing that feeds into the policy process at a very early stage. Then on the top of the slide, you see the immunization policy area of work. And again, there's probably about 5 people in the room that don't know what SAGE is. And for those 5 people, SAGE is the Strategic Advisory Group of Experts on Immunization. It's WHO's primary advisory body on immunization policy and advises WHO. You'll see in the next slide a little more detail on policy recommendations. On the bottom of the slide is the vaccine pre-qualification process. That's a totally separate process, and I know it's been mentioned a number of times in this meeting. We often just say PQ. And on the right end of the slide, you see that the SAGE recommendations and the PQ process both feed into the supply of vaccines through the UN agencies. It's essentially PQ, a mechanism to support countries that don't have a very strong regulatory mechanism. So this here is the schema, the more detailed schema on the SAGE policy-making process. In the center of the slide, you'll see the box that says SAGE, but really what you see on the slide, I'm not going to take too much time to walk you through every box here, but what you see is that there's a lot that goes into the final recommendations that may be half a page, maybe a full page, but there's a lot of evidence review and a lot of expert advisory committees that WHO relies on eventually to feed in the SAGE process. So very quickly over here, and apologies to those on the other side, but on the left side of the slide, you see a number of committees that review safety, that review the norms and standards, that review immunization practices, that review the quantitative and qualitative methodology for modeling, for example, and all of those feed into the SAGE discussions. We also typically have a SAGE working group that's focused on doing the detailed evidence review over several months, so that when the topic comes to SAGE, and it's just a couple of hours at the SAGE meeting, the evidence review is coming from a SAGE working group that's presenting their report essentially to SAGE for SAGE's consideration to issue the recommendations. And at this point, I'd like to acknowledge that several of the members of the SAGE working group on typhoid vaccines have actually been with us this week. And for me, that's quite thrilling, because it makes my work much easier in our face-to-face meeting coming up next month. And then just quickly, SAGE reports to the WHO Director General. And eventually, when the Director General approves SAGE's recommendations, it feeds or guides our development of the WHO position paper on a specific vaccine, and countries then use that to guide their decision making. On the periphery, you'll see that there's other processes for the regional technical advisory groups on immunization to feed into the country guidance as well. So let me just move on this walk. Specific to typhoid, I mentioned that there's a SAGE working group on typhoid vaccines that was created last year. And this working group is conducting the evidence review to support the recommendations, the draft recommendations that will be submitted to SAGE in October 2017 for SAGE to consider and issue the final recommendations. And that, as I mentioned, will lead to the revision of the position paper, we hope, next year. What do I mean when I keep referring to evidence review? This is oversimplified, but I just wanted to give you a sense, and this is where you begin to see all of the great scientific information that's been presented here, how it feeds into the policy review. So on this slide, there's two boxes, and one of the areas that feeds into that is the magnitude of the public health problem. So SAGE is going to be looking at disease burden estimates, epidemiological trends, risk factor analysis, what are the new data that have been generated since SAGE last looked at this in 2007. And for some vaccines, it goes much quicker, but for typhoid, you've all heard that our last recommendations were in 2007 from SAGE, published in 2008. Part of the magnitude of the public health problem will also to look at diagnostic and surveillance challenges, cost of illness and cost effectiveness modeling data, antimicrobial resistance. Then in the second area in my oversimplified representation here is the prevention and control measures. So again, there will be consideration about the use of the current licensed vaccines. Are there any new data that should cause SAGE to rescind the current recommendations that were made about 8 years ago, or do those stand, and on top of that, new recommendations on TCVs will be made? Integration with WASH and other strategies, we've heard a lot about that this week. Vaccine characteristics and performance. I mentioned a couple of minutes ago that we will be looking at any new and relevant data on the polysaccharide and TY21A, but obviously there's going to be a lot of focus on the TCVs because it's the next generation of typhoid vaccines, because it's now possible to use that under 2 years of age, etc. And so a lot of the vaccine information is going to be looking at both the characteristics of the vaccine, but doses, dose scheduling, effectiveness, immunogenicity data. We will need to immunobridge some of the data for the currently licensed VITT vaccines to the NIH vaccine that Sushant described this morning. And then finally, we look at programmatic issues as well, including what the target population should be for routine vaccination, delivery strategies and the considerations for those, and issues around vaccine management, etc. So in the next 2 slides, I'm going to try and encapsulate everything you've heard in the last 3 days. So from the epidemiological end, this is a broad landscape of the data that will help shape the vaccine policy revision in 2017 and beyond. And I think John Clements and others who have been involved in the dummy studies will be quite pleased to see that we are going to still rely on the data that were looked at 8 years ago from Dummy and Viva, etc., because they are still relevant. But then we've also had presentation of a lot of new new epidemiological data that have been generated and that were presented at this meeting, and I've listed here only a few of those sources, mainly the population-based bedding studies and the global trend study that Zulfi and his team presented a couple of hours ago, modeling studies, cost effectiveness, etc. The key point is that we've been working with all of these groups in the last few months. The dialogue continues. We've been trying to encourage the groups to provide us with the data in as timely a manner as possible. And many of the research groups have committed before publication, they're going to make the data available to the SAGE working group process, because that's what the data are for, moving evidence into action. And so I think that dialogue is proceeding very well, and we're thankful for that. Then beyond the SAGE policy recommendation, there's other considerations. How do we actually move from policy to country level action? And some of two of the key considerations that I've put here are, how do we actually optimize the data that have been generated in carefully selected settings to help other countries in typhoid endemic regions make their decisions? Is there a possibility to develop criteria that might allow country X to say, I have a similar demographic profile to Malawi or to Nepal, which did the burden studies? And is there a model that I can use to actually then help my decision making by extrapolating the Malawi or Nepal data into my own setting? So we need more thinking around this, and we'll probably have to develop guidance tools to help the other countries. Another issue, and this is a bit of a plea from WHO for all the groups that are putting in large investments, and certainly the foundation putting in large investments into these studies, to ensure that the surveillance capacities and any support that can be provided to national surveillance systems are maintained wherever possible. I'm not actually going to speak to these slides, but of course it kind of just reflects a lot of the presentation earlier today about the kind of data that are coming to the SAGE working group to consider from the licensed typhoid conjugate vaccines, and again looking back to the NIH VI report. Oops, that was quick. Okay, other key considerations for policy and vaccination strategies. On the right hand, you see the delivery strategy issues that Kathy nicely went through this morning. So thank you, Kathy. I don't need to go through it again. But then I just wanted to take a moment to reiterate that there are other issues around the TCV schedule. Of course, we need to have the burden under 2 years of age inform the policy around that. But there's also discussions already about the infant schedule already being crowded. If we're looking at a 9-month age of vaccination, for example, there's measles, rubella, meningitis A, yellow fever, on and on, some future RTSS considerations. And so some of these discussions will be considered, obviously, by SAGE, but countries are going to also be wanting to make that decision in the final stage with their own policy-making bodies. There's concern about multiple injections, co-administration. Switching gears a little bit, we've heard a lot as well about AMR, and I think it's clear that typhoid is probably going to be the first vaccine that goes to SAGE with an AMR agenda, and taking the agency of that message to SAGE, which is really an immunization body. So there's a lot of attention to that, and it's been mentioned many times here. I just wanted to highlight what was already mentioned, I believe, this morning, that WHO recently had an advisory panel develop the Global Priority Pathogen List, or PPL as it's being referred to now. And actually, as I have in quotes here, the panel stressed the importance of new antibiotics for the pediatric population and for oral formulations for diseases with a high morbidity burden, such as Salmonella typhi included there. There's also an activity that WHO coordinates, the Global Antimicrobial Resistance Surveillance System, or GLASS, and we need to work better with that group to see how we can leverage it to improve surveillance of Salmonella AMR at country level. I'm not sure whether Melissa is in the room now, but thanks to Melissa Coe from Gavi for sharing this information to be communicated to you. And so just very quickly, historically, the Gavi pathway to making a decision on funding for TCV goes back to 2008, again has been referenced many times. At that time, the Gavi board prioritized TCV for its portfolio, along with a number of other vaccines, but no financial commitments were made. And then in 2013, in the next vaccine investment strategy, TCVs were not revisited because it had already been prioritized. But this time, Gavi made a commitment to open a support window if a suitable TCV was pre-qualified. The next VIS is next year, and the discussions have started already. I mentioned in one of my opening slides that SAGE recommendations and PQ will be needed, and that's a standard process for Gavi. So the timelines are being considered, and the specific pathway is being considered in conjunction with Gavi for a decision about funding for TCVs. Just very quickly, I just wanted to show one of the guidance documents that WHO provides to countries to support vaccine introduction decisions. And this one highlights the need to look at the disease issues, the vaccines, the strength of the immunization program. And so again, one of the codes that has been so clear in many vaccine introductions is that the more visible and important the disease is to the community, the greater the acceptance. And therefore, data will be very important to support the vaccine introduction, and indeed has been recognized or cited as the major driver of demand and acceptability by many countries. I believe this morning there was someone in the audience who said, can we have these studies done in Zimbabwe to support our decisions? And that was a prime example of that. This might be my last content slide. So again, translating data to decisions and investments in typhoid control strategies, countries especially, but also at the global level, some of the issues are going to be, does the disease cause significant disease burden? Does preventing the disease align with priorities in the National Health and Development Plans and the SDGs? Is the disease perceived to be important to the public and medical community? Is control of the disease in line with global or regional priorities? Will it contribute to improving equity? And I'd just like to end with two messages on my penultimate slide. The first one is actually what we call an Edinkra symbol in Ghana, and those of you who've worked in Ghana have probably heard about Edinkra. It's a cultural system. It's very similar to having proverbs because each of those symbols has a specific meaning attached to it. And this is just acknowledging the amount of knowledge and learning we've had in the last 3 days, because the meaning of that symbol is he who does not know can know from learning. And I think all of us, coming from our various perspectives or the parts of the elephant, have learned from the other parts of the elephant in these 3 days. So I do acknowledge, I do commend Sabin for all the information you've shared with us. And again, I loved Mike's symbolism of the elephant. So an African proverb for you to take away: the elephant never gets tired of carrying its tusks. That's just to say we still have a lot of work ahead of us, so let's not get tired of carrying the tasks. And on that note, I just want to acknowledge all the processes that have gone into the thinking towards the considerations. WHO colleagues that I mentioned here, the SAGE working group on typhoid vaccines. Earlier this week, we had a side meeting to get inputs from several experts, BMGF, TIVAC, Gavi, etc., to help us really direct this pathway more. And at WHO as well, we appreciate very much the support that the Bill and Melinda Gates Foundation gives to our activities on typhoid. Thank you.
Thank you, Adwoa. Maybe clarification, one or two clarification of this policy-making process by SAGE, if anybody wants to clarify. Yes. Please identify yourself.
I'm Dr. Sally Ahmed from Egypt. Actually, I want to thank you for this great conference, and I want to ask you, Doctor, about the GLASS IT platform. We all know Salmonella species is one of the notifiable diseases in the GLASS IT platform, not Salmonella typhi. And does that indicate the global burden of Salmonella species is much higher than Salmonella typhi?
Yes, you're right. And I've had a very early look and discussion with my colleagues who manage GLASS. And so one of the concerns is that the data that are being reported to GLASS are on Salmonella species. And so this is why I made a point that we have a little work to do to leverage GLASS to actually improve surveillance for invasive Salmonella AMR. But thank you for making that comment.
Thank you very much. Bruce.
Thanks. Now our last plenary speaker is Dr. Rob Breiman from Emory, where he's the director of the Emory Global Health Institute. Rob wears many hats, but among those he wears in Typhoid is he chairs SUPPORT, which I think is one where the acronym came and then you decided that it stood for the Scientific Advisory Process for Optimal Research on Typhoid.
Yeah, thank you, Bruce, and thank you very much to Kat and Denise especially for asking me to speak at what is a very informative, exciting, often inspiring typhoid prevention love fest. So I'm going to start with a quote. Since we're focused here on evidence to action, this quote from Václav Havel: "Vision is not enough, it must be combined with venture. It's not enough to stare up the steps, we must step up the stairs." And now that's really what the remainder of my talk will be about. So during this talk, I'd like for you to ruminate on these three questions. So every time you drift off, bring yourself back to the center by thinking of these three questions, and then we'll come back to these questions at the very end. So question one, what additional evidence would be helpful to drive action? Two, which additional actors need to be engaged? We here are the choir, so we're all preaching to the choir, but what additional voices, what additional players need to be into this family, if you will, this togetherness that was mentioned at the start to be most effective? And then finally, what additional tools are needed? So I went back when Denise asked me to do this. I thought it would be interesting to go back to, it turns out there have been 11 sort of international symposia. I think the first one in 84, which was in DC, didn't count. It had like 35 people. I don't think that's counted among the other, when it's called the 10th International Symposium. But it's interesting to me that the numbers of, and there's a number of meetings where I couldn't find the attendee, participation list. But the numbers of attendees have been pretty much stable in the last several. The one in Dhaka hit a peak primarily because about half the attendees were actually Bangladeshis that came to that meeting and sort of raised that number. But what I think is most interesting about this graph, and I think important, is the line, which shows that the number of international participants has continued to creep up. And as was mentioned at the start of this meeting, there are 45 countries represented at this meeting. And I think that's very impressive and relevant to this issue of bringing the right people to the conversation. So looking back at the original meeting, there's a number of things that haven't changed much. And I think Zulfi was alluding to this when we just got up on the dais, that there were certain things that were said back in 1991 that are still being said. And one of them was highlighted in that first big meeting, how the diagnostic tests were really a problem. They were very limited, and there was a dependence on blood culture. There were new tests on the horizon that were being described, and those really were related to Tubex and what we called in those days Typhidot. And people focused on outer membrane proteins as potential tools. And there was a quote, "The search continues for the one simple, reliable, and inexpensive test." And I think we could still say that where we are today. And also there was a quote that is still highly relevant, which is, "Typhoid is mainly a disease of underprivileged people living under conditions of poor hygiene, sanitation, and education. And this was added, may take a long time to eradicate completely," I'll say. But I think where we are now, we're actually seeing the potential for such aggressive and optimistic approaches. And from the 2002 Karachi meeting, there was this quote. So around the turn of the century, there was a more of an attention on AMR and typhoid. And our own Gordon Dugan said there should be surveillance of drug-resistant typhoid at a global level, as we know the determinants spread very easily across political and geographical boundaries. And he could have said that today, and in fact they have spread and continue to. But then there are things that really have changed. If you look back and look at what was discussed in this very robust meeting we've just gone through over the last few days, there was a lot of discussion of molecular epidemiology and biology in the first meetings, things like ribotyping and PFGE. Obviously back then whole genome sequencing was not an option. And treatment was interesting because the treatment that people were talking about in 91 was with chloramphenicol. It was the drug of choice. And there was reference to fluoroquinolone treatment as being promising, but too expensive. It should have stayed too expensive, and then maybe we wouldn't have all this resistance. But it's interesting also that some of the data that was presented the other day, that when some antibiotics go off usage, like trimethoprim sulfa, cotrimoxazole and chloramphenicol, the resistance actually seems to drop out. So there's this potential for some of these old drugs to come back and be useful. And for vaccine, the discussion was all around VI and TY21A. The fact was back then the whole cell vaccine was still being used widely, despite having limited effectiveness. And there was a discussion of candidates, but in those days, no mention of typhoid conjugate vaccines. And now, not only are we spending time talking about TCVs, but we just had this wonderful session yesterday with going through understanding the immunology and the molecular biology associated with immunization through these human challenge models. I'll let this slide you absorb this slide. When we think of, at least when I think of this theme of evidence for action, to me it highlights one of the values of this meeting and a component of the value of the science that we are all taking part in. There is in that it's very heavily focused on better evidence and tools to drive action, sort of an implementation science approach. But there is a caveat down at the bottom of the slide, which is we should never, and we haven't at this meeting, discount the basic science, which may not have current implementation relevance, but will lead to that. So there was a very popular television show in the United States, and I don't know if others have seen this, of a mild, unassuming, mild-mannered and caring chemistry teacher who ran into some financial problems and discovered how to make methamphetamine and got connected to someone who could sell the methamphetamine so that he could meet some of his loans, meet some of his financial obligations. And he sort of inched his way into it, and he gradually, step by step, got more and more evil until he wound up as basically a drug lord involved with killing and everything. And so that show was called Breaking Bad. And what we're doing here is going in the other direction. Not that we started as evil drug lords, I don't want to suggest that, but that the movement is really towards science for action. And when I say breaking good, maybe it's what it should be is breaking even better, because it has been good all along. One of the things, there's many components to think about with this sort of analogy, but there's been a long history of vaccine development, during the past century with principal focus, there are some exceptions, on prevention of illness in wealthier nations. And there are a few, cholera vaccine would be an example, but there are a few of what I would call inequities vaccines that primarily address some of the SDP issues that Zulfi alluded to that are going to take a long time to address and solve as it relates to typhoid and other conditions. So an inequities vaccine would address this infrastructure issues and systems failures and diseases that affect the poorest of the poor. This isn't a vaccine that's being created for North America or Europe or potentially to be used, except maybe by some travelers. And so we have talked about typhoid conjugate vaccines here, and it's exciting to see that there's one now coming from India, from Bharat, but there are a number of others that are in the works. And we also talked about potential new vaccine strategies. So that is incredibly exciting. And we also learned about Tyvac. Now, Tyvac isn't spelled like this, but for those of you who've been involved with building houses, this is the layer that goes on to usually the plywood to keep it from developing fungus. And it's interesting, and leakage. It's interesting, this is a DuPont company, which you don't really think of in this way, but this is their slogan, for greater good. And so I think actually, wherever Kathy is, I think Tyvac should get together with DuPont. But I think what Tyvac represents is a huge opportunity where we are right now with a well-funded program to accelerate the development and use of typhoid vaccines, to include advocacy, which is one of those things that needs to happen, is part of the stars aligning, and something that many of us really couldn't have imagined a decade ago or so. And great credit obviously goes to the Gates Foundation and to Anita specifically for driving this. In addition, these multi-country surveillance projects, and Strata should be included on this as well, are also exciting. They're imperfect because of the challenges in doing population-based and sentinel surveillance in multiple countries, but they're doing great work, and I think that's going to add to the body of information of what needs to be prevented. Their focus, especially for CETA and CEP, is not just on incidence, but on the proportion of, or the types of, the sort of the tip of the iceberg, the severity of disease, and characterizing the spectrum. And there's a long list of things that CETA and CEP will do, but I wanted you to note the bullet that's in italics, which I think is very important, because this was a major theme of this meeting and will probably be a major part of advocacy, which is related to to antimicrobial resistance, as it was in 2002. But at this meeting, we've been talking frequently, or people have talked about the post-antibiotic era for typhoid fever. And there's a lot of data that hasn't fed into that yet. And this will be an opportunity to explore the relationship between antimicrobial resistance, antimicrobials prescribed, and outcomes. So this is a brief interlude. A number of people have asked me to talk briefly about what I spend most of my time doing. And it relates to something that Zulfi had brought up, and it's not unrelated to our issues with typhoid. Because despite the dramatic reduction in childhood mortality that we've witnessed, childhood mortality remains very high in many parts of sub-Saharan Africa and in South Asia. And so we are now embarking on a study a program really, of surveillance in 7 different locations that will begin to characterize with much more granularity than we have now what is killing kids under the age of 5 in some of the highest incidence places. And so these include Mali, Ethiopia, Kenya, Mozambique, South Africa, Bangladesh, and Sierra Leone. In Sierra Leone, for instance, the childhood mortality rate at the site we're working in is between 120 and 150 per 1,000 live births, which means that by the age of 5, between 1 in 6 and 1 in 7 children die. It involves collecting tissue samples through a minimally invasive approach. And one of the reasons I'm bringing this up is one of the sites is bone marrow, and specifically why we're doing bone marrow. Essentially, there will be other pathogens like TB that we'll find there, but it's especially to find if there's presence of S. typhi, where we can document typhoid fever contributing to mortality. We also have this approach of data to action, very much like what we're talking about here, especially at the national level, and ministries of health and national public health institutes are deeply involved. And so coming back to the questions that I posed at the outset, and I know you've been ruminating on this, I have my own ideas, but when it comes to what additional evidence would be helpful to drive action, things that I would list would be, again, ensure, because AMR is such an important thing to be talking about, because the idea that we will no longer be able to treat typhoid and will return to case fatality rates back in the pre-antibiotic era, I think it's very important that we provide evidence, good data for that, and not just say that. And I think we will have the opportunity to provide that evidence. I also think that this is such a great chance to evaluate the efficacy, effectiveness, and the impact of vaccines, both through the sort of trials that we just heard about, but as well as hopefully in other sorts of demonstration projects, maybe vaccine probe efforts as well as this program keeps moving. And I also wanted you to think about, or I know that people have been thinking about, the role of environmental and sewage surveillance to help fill in. We can never do surveillance in every location, but to help fill in what is known about the presence of typhoid fever in these locations. And also to characterize the increasing mobility of people, making typhoid more egalitarian. I put in this road being built. In Africa especially, the explosion of tarmac roads has been really evident over the last 5 years, and it's partially responsible. It's a very positive thing economically, but that mobility of people is very much part of what happened with Ebola, especially in Sierra Leone and Liberia. And if you think about it, it may also be involved with how pockets of typhoid fever may be spreading and allowing rural to urban or urban to rural typhoid to occur. And then under which additional actors need to be engaged, the thing I'd really like to focus, and maybe at this next meeting it would be wonderful to have this, would be to engage and involve national public health institutes, which are like mini CDCs and exist in 80 or more countries. And in fact, Ilash Jani, who's here and is the head of the working group that Adwoa was just talking about, is the head of the Mozambique National Public Health Institute. To have them really engaged in this, because their whole approach is translating data into policy, as well as to work with up-and-coming local public health leaders, either through the FETP programs, as well as standard MSc and PhD students. But also think about how the media should get involved, the business community, and although I can't talk about it here, Zulfi also had alluded to this, is that there's this movement on planetary health, bringing together all of these issues related to planetary changes on our planet that are occurring at an accelerated rate never to have been experienced before. And many of those components increase the risk of typhoid fever. And finally, the additional tools on this list include better diagnostic tests, there it is again, more vaccine options, ensuring supply, quality, and efficacy. I think more genetic epidemiology to understand how S. typhi and INTS moves around, changes, and becomes more dangerous. And the big elephant in the room, bringing the elephant back again, that we haven't talked at all about in this meeting, or maybe I missed it, is the fact that there is treatment options. We're still stuck with the same set of treatment options, and that really needs to be addressed. So finally, leave you with a quote from Mark Twain: "Action speaks louder than words, but not nearly as often." And I just want to say at the end, again, I'm really grateful to have been able to be here at this meeting and to hear about all these great things that are happening. And clearly the stars are truly aligned for action on preventing typhoid. Thanks very much.
The fourth or fifth slide where you put what additional and 3 options in it.
You want to put the original one?
The original one, just the 3.
Yeah.
That one?
Yeah. Thank you.
Maybe this would be a chance for those of you who have ruminated on this to add to what I provided, or if you have questions or clarifications.
So we will have about 10 minutes of observations, comments, questions, clarifications. Please go ahead. Maybe we can start with you.
Hi, I'm Eileen Quinn with PATH and TIVAC. Mark Twain also said that a lie gets around the world before the truth has put its boots on. So I think we do need really effective advocacy for this disease. So the other actors I would suggest are child health advocates, groups who are already implementing vaccines, groups that are supporting the Gavi funding, pediatricians, and healthcare workers in general. And we really need to do a better job in partnering with WASH advocates.
And that's such a great comment. I also wonder if you think we need more social behavioral science and understanding what people are thinking. It was alluded to in an earlier talk, a previous session, so that advocacy could be more finely tuned and effective. Chris.
Just wanted to say what a fantastic conference this has been, but to reflect that there have been no presentations of randomized controlled trials of treatment for typhoid. So to follow on with your elephant, so we heard today about the outbreak of ceftriaxone-resistant typhoid in Hyderabad, which is still ongoing, and that's a wake-up call, I think, that sporadic strains around the world have been reported, but eventually we're going to see more problems. In the last few years, the only group who've really been doing substantial clinical trials are Professor Bhutta and colleagues, Oxford colleagues in Nepal. And I think there's a need for trials of maybe new options for treating typhoid, perhaps combinations, perhaps other options. And just to comment that with these networks that we now have generated, that perhaps there's an opportunity to have multi-center trials, simple multi-center trials of sensible antimicrobial regimens that can generate sufficient numbers to give a properly powered study to give a result that then translates into policy.
And the epidemiologist in me also, each time an outbreak like that happens, it would be very nice to see a comparison of what the strains were resistant to and how those patients were treated, even if it was for the first 72 hours, and how a mismatch affects outcome. I think we'll have, unfortunately, more opportunities to do that.
Thank you. Yeah. This side.
Thank you very much. I'm Inusa from International Vaccine Institute. I have a comment and also a question to Adwoa and also to other seniors seated in front. The question is, as we look into mechanisms and factors that actually will lead to easy adaptability or acceptance of the possible TCV candidate that could receive the WHO PQ, has there been any group or expert group within the WHO set up to also tap on the experience of people or scientists in different countries that actually have gone through a lot of challenges in implementing or rolling out vaccines? And then what is their success stories? What psychology or strategy did they use to overcome those challenges? Because as we burn through the midnight candles to do all researches and move the vaccines from bench to board, we shouldn't also forget that even if the policymakers accept the vaccines, the intercultural dynamism and all the dynamics that could also stand against the implementation of the vaccine shouldn't be forgotten. Because some people in hard environment have actually given example that they had difficulties in reaching out to people, but with time, there are some steps they took which actually became a successful story. So in this, I wanted to ask, is there any expert group of sociologists from different countries also within the WHO that looks into the possibility of the people accepting the vaccine after the policymakers have accepted it?
Okay.
Thank you.
So we will we'll take a couple of questions and then respond to. Yes, madam.
I just have a rather unscientific comment to make, and I know the last thing that scientists like to think about is fundraising, but listening to you, Rob, it strikes me that the typhoid community might be at a tipping point where public-private partnerships might be possible as implementations are rolled out, as you collate the data around transmission pathways related to sewage and other things, and as you had the Tyvek slide up there, which was great. You know, DuPont, a quick Google search, they do a lot of funding around the world in sustainable agriculture. And so, you know, having spent 30 seconds looking at it, I just wonder if it might behoove the community to think a bit more about fundraising in a creative way moving forward. And maybe at the next conference, we'll have less Bill and Melinda Gates Foundation and a lot more donor representation. And so, thank you.
Thank you.
Actually,
We would request to be very brief so that
okay,
more
actually,
people.
I'd like to ask about standardizations, not only for the case definitions of typhoid or salmonella species food poisoning, and also for lab diagnosis. As I noticed from my speaker and presentations, some people doing conventional cultures, some people doing backed blood culture, some people doing automated identification system with sensitivity. And as we know also in microbiology, sensitivity with Vitek is not highly recommended because of the E-test or micro dilutions with only 4 dilutions. The phenotypic in plate disk diffusions or E-test is better. So I would like to have just a standardized protocol for diagnosis of salmonella. Thank you.
To Enusa's question, I think you raised some great points. We don't have a standing advisory group at HQ, but certainly the regional advisory committees on advisory groups on immunization are probably closer to the action, if you will, at country level. And I'm sure they get a lot of the feedback from countries on the lessons learned for vaccine introduction, etc. Some of that comes to SAGE sometimes, and there's various activities at WHO that look into those issues as well. But that was a great point. On the issue of standards, maybe just to share with you that we've actually just recently started some work to develop surveillance standards for invasive salmonella disease for typhi, paratyphi, and INTS. So hopefully WHO will come out with some guidelines next year that will help to streamline some of this or standardize some of that. A lot will depend on the resources available at country as well, of course, but it's an important question.
Thank you. Yeah.
Hi, Karen Kelly, NICD South Africa. Just kind of linking into both Zulfi's talk as well as Rob's talk is we're networked pretty well, but the bacteria are pretty well networked as well. And one of the things that's always concerned me with the management of typhoid fever is our 3 major drugs in our armamentarium are actually the same as the 3 major drugs in the armamentarium that are used for treating STIs. And every time you treat an STI, because it's the very, very short course, I suspect we are actually under-treating our salmonella, which may also be a problem driving resistance.
Bruce, you would like to make...
I wanted to briefly comment about the last inch, if you will, of the last mile of getting not only going through all the work of developing vaccines and to getting them to the clinics, but also on vaccine acceptance. Narendra and I were a part of a SAGE working group on vaccine hesitancy a few years ago. I encourage you to take a look at that final report. And one of the outcomes of it was we recently organized a meeting that was sponsored by the Rockefeller Foundation in Bellagio to try to think through this very issue. And it's trying to bring together mostly the social scientists to try to better understand what the issues are, how to measure it, and how to measure the impact of interventions. So I think, Rob, your comment about bringing social scientists and to make sure that our messages work for advocacy are equally important for this area.
Thank you.
So I think,
Okay.
Samir first.
Please go ahead, one of you.
Okay. I think it's important to reintroduce typhoid to the WASH community, because in the WASH meetings, people don't talk about typhoid. People at WASH meetings currently think they have moved beyond diarrhea and they're focused on stunting and environmental enteropathy, and nobody's talking about typhoid. So it's worth reintroducing the topic to the WASH community. Thank you.
Thank you. Samir, thank you very much for that point.
So I'll take Rob's one point. Who are the other actors should be included? I'll say industries will be a very important actor, in fact, in this. The reason the countries are really feeling, the politicians are feeling a huge triumph when they are graduating to the middle income countries, but that's a bad news for any vaccine production. And for typhoid, the supplies would be a very big could be a very big problem. Bangladesh suffered for delayed 3 years for pneumococcal vaccine when they, after even Gavi approval, and Bangladesh will be maybe not getting Rota vaccine even in time because there is again supply issue. And typhoid vaccine will be going to those countries, not like Italy, Germany, these small birth cohort countries. It will be going to the countries with millions of birth cohort. So we need to prepare from now, when we'll be ready with the evidences and advocacy and Gavi approval, that we are really getting supplies in time. Otherwise, all the advocacy and whatever we are talking today, it seems all will be going useless, in fact. Thank you so much.
Thank you. Thank you very much. Yes, sir.
Yeah, thank you. I want to talk about the teaching institutions, because immigration in Africa is also, it involves the movement also of health personnel. So we're always having newer and newer health personnel to diagnose. So I think typhoid management also should look at teaching the newer medical practitioners, the nurses, the correct public health management of these diseases like typhoid. Thank you.
Thank you. Before Andy, I request you to make your comment. I thought the point made about WASH, during the course of last 3 days, to me, there were 3 major challenges which came up. One is AMR, the other is WASH-related issues, and the third is diagnostic tools. On the background that typhoid is a disease of poverty, and the poorest of the poor suffer the most. And when Zulfi was presenting the issues of the alignment with the SDGs, we see a clear alignment. When I look at AMR, and when I heard this issue of ceftriaxone resistance, and for last 6 months, constantly cases coming, I think we should look at agriculture, we should look at animal husbandry, we should look at food processing and move beyond health sector as well. It's very important. AMR is not only the problem of biomedical sciences and systems. Unless we move beyond that, we may not be able to find solutions to this. Similarly, for WASH, I thought I would give the example of my country, India. It is only recently, for last 2.5 years, that after major governmental investments came into WASH, that things have started moving. Keeping hygiene, having clean water, having toilets, open defecation-free environment does not come in free. One has to have investments. And unless non-health sectors and the political system is involved, I don't think we will be able to achieve the WASH issues. And the third component, which I thought, and the point we are talking about actors. So unless we get these actors, it becomes very difficult. We look at politicians, we keep on blaming the decision makers, but I think the politicians are the brightest human beings on this earth. They make decisions, and decision making is not an easy task. They are accountable to people, and unless we take a very holistic view, and typhoid is a very good example, and many times we feel that we health people can manage it separately. I don't think so. Neonatal tetanus is another disease of poverty, and the world has shown that we are able to reach that poorest of the poor and prevent this neonatal tetanus. It occurred only because the governments came on board, and today only I think 8 or 10 countries are are left with neonatal tetanus. So there is a residual thing. Polio could not have been interrupted in most countries unless the other systems were involved. So I would request the typhoid community that if we want to really move forward, we have to move beyond biomedical field, and non-health sectors have to be involved in all the seriousness. And in the subsequent meetings, unless we have people from other sectors sitting along with this, and this requires a paradigm shift. Polio has been, we have moved further in polio because I think CSOs were involved and the other sectors have come on board. And similarly for diagnostic, if we look at last 10 years major advance in typhoid, it is the industry which has come up, and we have these very good vaccines now available where all of us are excited. So I think a shift in our thinking process, that how do we move and get new actors, then only new tools and new evidences can come. So that's my take on this conference. Andy.
He was then.
You were before, and then I'll come on.
Thanks very much. I mean, it feels at this sort of stage in the meeting as if the mood has dropped a little bit. I don't know whether that's because of the thunderstorm or the rampaging elephants, or perhaps it's the drug lord who gave the last talk. But it does feel as if the mood's dropped, and I think it's because of the challenge that's just been, I think, laid out by those last few talks, particularly of the big explosion that we've seen in disease in Africa, and the feeling that that may continue to get worse, and the antimicrobial resistance problem, which does feel extremely concerning at this moment in time, because we don't really have good solutions or evidence guidelines, as Chris just pointed out, to drive forwards about how to manage those. But I actually feel quite optimistic, because we are in a position where we have the potential to make a big difference here with the availability of vaccines. And so I think we should probably be a bit more uplifted at this point in the conferences. Maybe we're just getting a bit tired, but I think it's actually a very exciting point where we can make a difference.
Thank you very much for your presentation. The last presenter has actually summarized, but I have some issue about the SDGs. And I have a feeling that there is, especially in my country, I'm called Denise. I represent the media in Uganda. There is a feeling of a disconnect between the SDGs and actually what is on the ground. And I have a feeling that this could be part of the data problem, how data is generated. Is it possible that the data collection can be improved to support this process so that the goals are actually achievable, but not something that is just ambitious that cannot be achieved? Secondly, the issue of policy makers, and one of the presenters actually raised it. If we have to include typhoid in the SDGs, it means the policy makers at the high level should be part of it. And therefore, do you have a framework, or do you have an idea of bringing policy makers at different levels up to at the country level so that they can support this process? Thank you very much.
So I don't think we should be too worried about the SDGs being overambitious at this stage. This is actually exactly where we were with the Millennium Development Goals, with the MDGs. The issue with the MDGs was that because it was imposed at that time, and I was a member of one of the groups that set up some of the targets, we did not have even a fraction of the data that we have today. And there wasn't the consultation that took place within civil society around the SDGs. So I think there is a huge data challenge because a lot of the indicators that have been set up as part of the SDGs are currently not being collected. They are being developed, and they will be gradually over the next few years part of the reporting processes. But you don't reach anything that you don't aspire for. And therefore, setting up some of those goals of universal access, some of those targets around getting information on who are the marginalized who are not being reached, and ending preventable mortality, not reducing preventable mortality, ending preventable mortality. Those are lofty goals, and countries are aligned behind them. The disconnect that you feel right now is because we are in the first year and a half of the SDGs. We still have another 15 years to go. And I'm reasonably confident that not only will you get a new framework of data collection, you might get new indices. So I would, if you have an opportunity, read the paper on the Sustainable Development Goals Health Index put out by IHME last year. It is a fascinating look at data as to how we can use existing data to come up with better measures. And as we move forward, I think those are the opportunities to include the kind of indicators that I was alluding to. Things that have antimicrobial resistance, access to diagnostics. Currently in our countdown reporting on maternal child health, we only report on 2 diseases for care seeking and care, diarrhea and pneumonia. Why can't we include febrile illnesses within those? I mean, and those febrile illnesses could be malaria in some places, could be in South Asia context, not malaria, but typhoid and dengue. So I think there are huge opportunities here, and what may look like a big challenge right now is, I think, something that we should, as a community interested in typhoid, accept and move forward.
So maybe we'll wrap this up. Adwoa and Rob, if you have any closing comments you'd like to make before we move on to the final session.
Not really.
Okay. All right. Thank you. Thanks.
So, Bruce, you.
All right. So I wanted to, you've been all looking at the agenda and your clocks, and you're right, this is the closing, and I wanted to primarily thank you for coming and for coming all this way and for all the thoughts that you've had. Like Rob, I too had a chance to look back at some of the origins here. I don't know if the slides are coming up or not, but it was a chance to look back and see how far the community has come. And similar to Rob, I thought it was important to have a quotation from a great person. And so I went to Dr. Levine, because this was from the report of the very first, the 1984 version that Rob thinks was the pre-first meeting. So that's how we got to 10 rather than 11. So at that time, in the summary that was published in 1986, Dr. Levine told us that this was an exciting research was presented. It engendered a sense of optimism among participants for improved worldwide control of typhoid fever. Now, how do I click? I've been watching everybody else do this. Maybe somebody could advance this. What's the trick? This is like when you're in a computer, when it takes two people to look over your shoulders to figure what's going on, you have trouble. So the point of this is, so you'll see coming up next, if this ever shows up again, is that this was 1984, was when Mike wrote these words. And it's now more than 30 years later, we have the same sense here, but a lot has changed. The next slide, should you see it, was actually similar to what Rob showed. If you could advance the next one, and the next after that, was that these are some of the, next after that, please, these were some of the highlights. This is the 1984 meeting focused on the potential of vaccines. There were a lot of discussion about epidemiology and the difficulties in quantifying illness, the differences in case fatality rates and severity in different places. I'm not sure if it was a baby elephant at that point that's become a full elephant. And interestingly, in 1984, the comment then about the relatively low prevalence of antibiotic-resistant strains. You've heard many times how the world has changed and how many years later things are different. Next slide. So I think that am I doing this? So I didn't make a graph. I started before that first meeting, and again you can see how much has changed, as Rob pointed out. 31 participants versus more than 300. 13 countries, now 45 or 46, depending on which tally you look. Things have come a long way. And to me, coming into this new, frankly, to see this grand coalition of the many sectors who are involved, and I think what we heard on this panel was the need and the opportunity at this inflection point to broaden that coalition to the many stakeholders who have a piece in this. Zoe's comment about public-private partnerships I think is equally important, because there's a lot of communities at stake here. The business community suffers when these happen in their communities as well. So I was glad to see the structure that Rob put forward about those 3 questions he asked. We had some great input from all of you. I encourage you to continue to give us your thoughts on those areas, because it needs to be a broad reach across if we're going to try to take on typhoid. The next slide. There are just 2 left. This I borrowed from Seth Berkley. This is not necessarily a Gavi advertisement, but I wanted to point this out because, as we've heard before, and Adwoa mentioned it, the Gavi has a vaccine investment strategy of how they decide to make decisions on what are priority vaccines. I put this up here because not just for Gavi and the Gavi countries, but essentially in every country, as this vaccine becomes available, the case is going to need to be made that it's worthwhile for a country, that it's good value for money, that it's got the potential to make a big difference in terms of the health impact. Interestingly, and this is why I wanted to highlight it here, in the upcoming vaccine investment strategy, there are different additional criteria that are going to be factored in. And I think it's very important for this community to look at them, not just for how this plays out in the Gavi world, but again in making the case in every country who's going to try to decide whether or not they're going to introduce this vaccine. The role of AMR and how a vaccine might affect that, whether or not the disease has epidemic potential, and the potential for eradication. We don't necessarily use that E word in this community, but I think that we see that there's the potential, given that this is only a human disease. And so now the last slide is that I wanted to, and there's one more on if you click it again, is that really to say that, to thank you again, and to thank all of you for coming, to thank the Sabin team and the CAT team for putting this together and for taking the theme of this conference seriously. We've talked about a lot of evidence, and what we tried to capture in this last session was how we're going to really move that to action. So we have the coalition that I think, as we talked about, needs to not only continue but to be expanded to bring in all the other sectors to solve this problem. And we've now had the opportunity to introduce TIVAC as a new member of that grand group, because on top of everything else, we know that a vaccine is not going to solve this problem by itself, but the opportunity for this new vaccine, the attributes it has, and the potential it has is why we wanted to have that here as well today. So again, thank you all for coming. And I want to leave it to Denise who is responsible for pulling this all together. So let's give her a hand for this, and she'll really wrap things up. Thank you, Denise.
Okay, this is going to be really fast, and I don't have any slides. So it's been such a great pleasure hosting you for this conference, and as I mentioned at the opening session, we worked on it for almost 2 years. It has been incredible for me to watch it all come together this week here in Kampala, and I hope you have enjoyed it as much as I did. I would like to thank you all for participating, especially the presenters for the thought-provoking presentations. The presentations will be available on our website next week. So as a reminder to presenters, if you do not want your presentation publicly available, please let us know. After all that was shared here these last 3 days, I feel, and I believe you all will feel the same, I feel re-energized and really passionate about the future of typhoid prevention. But we have a lot of work to do, a lot of work ahead of us. For me, this conference has really highlighted that it's not the work of just one person. It's not the work of just one research group. And it's not the work of one research group that will make a change, but as it's commonly said, it's the work of a village. And as of last night reception, we have officially welcomed TIVAC to this village, and we are looking forward to working together to take on typhoid. So though the conference is just ending, the wheels are already in motion for the next one in 2019. These 2 years, I know, will be fast-moving in the typhoid world, as this last session illustrated. So while all 300 of us will probably not be in the same room until the 2019 conference, we at the Coalition Against Typhoid, we remain a resource for the community. We are here to help you, to make sure you all remain connected, to spread the word about exciting new research, and to help coordinate us as we forge ahead in the fight against typhoid and the other salmonelloses. So thank you very much.